Natalie Roshnik. It's an honor to welcome everyone to our webinar on malaria control through schools, showcasing our work from Mali. And this is being held in celebration of World Malaria Day on April 25th. So we will be presenting to you the latest evidence, the news and developments on the ground, and explore a little bit about what all this means, not just in terms of policy in Mali, but also in terms of relevance for programmers in other countries who are perhaps considering incorporating malaria control into their programs. So as you know, Mali has become a bit of a hotspot for innovation in this area, and Save the Children has a long-lasting school health and nutrition program there that has included malaria prevention and control. And we've been partnering with the London School of Hygiene and Tropical Medicine, as well as the Institut National de Recherche en Santé, to conduct various scientific studies. And these studies have been generating findings that are of relevance beyond Mali, beyond the borders of Mali. So anyway, without further ado, let me present to you Sian Clarke from the London School. Sian is a malaria expert with a long history of conducting research in Mali and has been partnering with us. And she has been awarded a Wellcome Trust Fellowship to investigate the epidemiology and control of malaria in school-aged children. So Sian will begin by providing a quick review of the evidence to date. And we will follow that with a presentation either by Sebyou from Diarra from Mali, if he's able to join, or by myself, as I will try to take over. And then we'll take the discussion on, we'll look a little bit at global significance and relevance at the end that Sian will lead. So over to you, Sian, please.
Okay, thank you very much, Helen, for that very good and clear introduction to what we've really been trying to do together with Save the Children in Mali. So I'm based at the London School of Hygiene and Tropical Medicine, and we've been working together with Save the Children in Mali and also actually in Malawi to look at generating new evidence of what we can do in terms of improving control of malaria in school-aged children in particular. So during the presentation, I'm going to kick off with an overview of malaria control in schools and the trials that we've undertaken together in Mali, and then Sebyou is going to take over and discuss what's happened since the trial and the more practical lessons for program implementation, and then we'll round up with a session of questions at the end. But do feel free to ask questions as we go along as well. So why are we interested in malaria control in school-aged children? Well, one of the main issues is that malaria control has generally focused on preventing malaria in children under 5 years and pregnant women, I mean, which is quite right, because those are the ages at which the risk of death from malaria is greatest. But as a consequence of that focus, we know relatively little about the impact of malaria in older school-aged children. And so we don't necessarily have that much information on the role that schools can play in improving malaria control in this particular age group. Next slide, please. So essentially, this slide is to demonstrate how there are two different ways in which malaria infection can impact on school children. It can cause clinical attacks, but in areas with very high transmission, children normally develop some immunity in early childhood, and so by the time they get to school age, they don't necessarily experience as many clinical attacks as when they were younger, but nonetheless they do still remain exposed and they become infected, and asymptomatic parasitemia is quite common. So although the main impact of malaria in school-aged children is probably through asymptomatic parasitemia, we do know that depending on where the children are living, between 20 to 50% of them will experience a clinical attack of malaria. And malaria remains a major cause of death also in this age group. Because of the asymptomatic infection, this contributes to anemia, and quite often the level of anemia in school children is quite high. So a lot of the malaria control that we have been doing or investigating has been trying to focus on reducing this burden of anemia. And we're interested in that because we also think that there's potential for anemia to impact on concentration, reduce attention during lessons, as well as contributing to absenteeism, which of course children with fever clinical attacks will also be absent from school. And both of those will ultimately impact on what children are learning in school. Next slide, please. So this slide is to illustrate that how asymptomatic infection is particularly important in this age group, and how the levels of infection in school-age children are much higher than they are in younger children. And the primary concern of these asymptomatic infections is because the children do not present with any symptoms, that the infections will go undetected and untreated, potentially for long periods of time. Next slide, please. So in terms of what schools can do about malaria, there was this toolkit published by the Partnership for Child Development, in 2010, which highlights why the education sector should respond to malaria, the benefits of controlling malaria, and also identifies some appropriate malaria interventions that can be delivered through schools. Next slide, please. But since the publication of that guidance, there are a number of new and potential strategies that schools could also consider. And this is an area of potential future research. So thinking about the existing strategies, schools can have an important role to play in malaria prevention education, particularly conveying key messages, using children as agents of change, in terms of improving children's education, knowledge and perceptions directly, but also for the wider community. And schools can also play a role in distributing nets and promoting the use of nets during campaigns. But there are three newer strategies which are involved with drug-based treatment, which could also be considered. So the first of these is intermittent parasite clearance, and this focuses on those asymptomatic infections and is a periodic treatment which aims to clear infection, and it's something that can be potentially delivered through schools. A second strategy is a new strategy recently recommended by WHO in 2012 called seasonal malaria chemo prevention. This approach focuses on preventing the clinical attacks and is recommended for areas of highly seasonal transmission. The recommendation is to target children under 5 who are at greatest risk of clinical malaria and morbidity. But ECD centres attached to schools could potentially play an important mobilising role in this intervention. And in some countries, seasonal malaria chemo prevention has also been scaled up to include children up to 10 years of age. So Senegal, for example, is providing seasonal malaria chemo prevention to both those age groups under 5 and 5 to 10 years. And another important role for schools, and this is something which Save the Children has been leading the evidence on in Malawi, is the use of learner treatment kits. This focuses on identifying clinical attacks, diagnosing them using a blood test, and providing prompt treatment for the clinical episodes. The teachers have been trained to perform the test and to provide ACTs or refer the child for further treatment. Next slide, please, Alicia. So this is just to illustrate, if we were to overlay those different strategies on the causal pathway of how malaria might impact on education, how ITNs and intermittent parasite clearance are really aimed at preventing infection and the consequences of asymptomatic infection on anemia, whereas strategies such as seasonal malaria chemo prevention aim primarily to prevent clinical attacks, and case management is to reduce the impact of clinical attacks on anemia and school absenteeism. Next slide, please. So moving now quickly to the context of Mali. Mali is located in the center of West Africa. It's an area of extremely high risk of malaria and experiences an intense seasonal transmission for about 6 to 7 months of the year. The malaria risk is greatest in the south of the country, and the study was carried out in Sikasso, which is shown in that red spot at the bottom of the country. In Mali, generally, the educational indicators are poor. Primary completion rate is not great. There are high levels of low literacy rates, rather, and school repetition is also a concern. But yet, almost half of the population are under the age of 15, and with high school enrollment rates, the school health programs have the potential to impact on a large proportion of the community. And that's something we can come back and discuss a little bit later. Next slide, please. In terms of the malaria in the Sahel region, of which Mali is one of the countries in this band just below the Sahara Desert, the incidence of malaria is highly concentrated in just a few months of the year. So this is some data from Senegal, but it's typical of the pattern you would see throughout this region. So the most malaria attacks are occurring in the months of September, October, and November, at the end of the rainy season, and around about the time that the schools, part of the time when schools are closed and when schools start to reopen. And it's a very distinct epidemiology and disease burden in this part of the continent. So you've got the single period of transmission. Because immunity is acquired more slowly as a consequence, clinical attacks remain quite frequent in school-aged children compared to other parts of Africa. But at the same time, asymptomatic infections are also common. Next slide, please. So the aim of the study was to mount a comprehensive school-based malaria control program, and we wanted to evaluate cognitive and educational outcomes as well as health outcomes. Next slide, please. So the intervention combined the use of ITNs and intermittent parasite clearance with the intention to protect the children during the rainy season with the ITNs to reduce the risk of being exposed to malaria infection in the first place, and then the intermittent parasite clearance was to treat the infections that had occurred as to minimize their impact on anemia. Next slide, please. So the intervention itself consisted of two phases. There was educational activities in the school, which was associated with a net distribution. The teachers were trained in a number of different activities they could undertake within the schools and with the children. A participatory approach was encouraged, and the teachers were sort of free to develop their own materials and approaches. There were supporting activities such as malaria clubs that undertook surveys of net use, for example, in local communities to raise awareness amongst families as well. And the children often did things like developing dramas, poems, songs, and so on before performing in the community. But there was some freedom about the different kinds of educational activities that different schools might choose to undertake. Next slide, please. And then at the end of the dry season, shortly before the beginning of the next rainy season, the education was supported by a distribution of nets within the schools, and at the distribution days, the children often performed the dramas and the songs to raise awareness amongst the community. Next slide, please. And then this was followed in December, at the end of the transmission season, with a malaria treatment with the intention to clear the parasites. And this treatment was given by the teachers, and it was given just once each year. And in this approach, all the children are treated, so it's irrespective of their infection status, and they receive the treatment for 3 days. So it's in very many ways similar to sort of a deworming type approach. Next slide, please. The government of Mali was involved in a number of ways in the intervention trial. So a key research partner was the Institut National de Recherche en Santé Publique, where the PI was based, and who also provided technical support for the biomedical surveys. The National Malaria Control Programme was involved in supplying drugs and in the training of teachers and district health officials. The district health officers were also involved in the teacher training and had oversight of the intervention, were often present in the schools at the time the treatment was being given. And district teachers associations were involved in the administration and marking of the cognitive and educational tests, which we use to assess the impact on education. We're also involved in the development of the teacher training and had oversight of the intervention. Next slide, please. So this was the basic timeline of the survey. There were 80 primary schools in Sikasso in southern Mali recruited into the trial. 40 were randomized to receive the intervention, and 40 were randomized to be in the control arm that did not receive the intervention. We undertook a baseline survey prior to the distribution of nets in schools and the educational activities to promote their use. And unfortunately, fortunately for the children, but unfortunately for us in terms of the evidence generation, that was followed 1 month later by a change in the national policy to a universal distribution of long-lasting nets to all age groups. So actually, all the children in the control schools would also have received nets as part of that national program. We undertook a follow-up 1 year later, and then that was followed by the intermittent parasite clearance, and then the final evaluation was done in February 2012. Next slide, please. So I think we can quickly pass through this. We looked at the health outcomes. So in terms of what did we find? It's okay, sorry, let's move forwards. I'm kind of conscious of time. Can we go back one? That's it, thank you. So we saw a significant improvement in knowledge amongst the children in terms of bed net use and how malaria was transmitted and the differences between different types of bed nets. Next slide, please. And we also saw a marked improvement in the number of children in this age group that were sleeping under net. So at baseline in November, before any of the malaria mosquito net distributions, only about 40% of school-age children were sleeping under a net, whereas in August, during the peak of the rains, when the numbers of mosquitoes are highest, in the control arm, following the national campaign distribution, almost 80% of children were now sleeping under a net, but a lot more of the children in the intervention schools that had been receiving the educational activities to promote net use were using their nets. And then in November, 12 months after the original baseline survey, we could see a significant difference between these two groups of schools. And that difference persisted until February at the time of the final survey. In terms of the impact on health, this slide shows the percentage of children infected. So this is the percentage of children that had malaria parasites detectable in their blood. And we can see that, in fact, there was a significant difference in November 2011 between the control and intervention schools, although that difference is relatively small. But there was a dramatic reduction in the asymptomatic infections in the intervention schools in February 2012 after the parasite clearance compared to the control schools. So in the control schools in February, at the end of the intervention period, we were seeing 73% of children with malaria parasites compared to just 3% in the intervention schools. And what was also important was that we saw a reduction in gametocytes, and gametocytes are the form of the parasite which can be transmitted to mosquitoes and can therefore infect other people. And there was also a significant reduction in anemia from 45% of children in the control schools down to 35% in the intervention schools. Next slide, please. So we followed up a subsample of children in the two groups of schools at the end of the school year in May 2012, and found that the impact was sustained. So this difference that we'd seen in February was still visible in May, despite no further intervention. And this difference remains significant. Next slide, please. And what was particularly interesting about the trial is that we also saw an impact on cognition. So we performed tests of sustained attention, and in this we saw a impact with children in the intervention schools performing significantly better on the double-digit test score. The double-digit test score is actually slightly harder test to do than the single digit, and that's partly why we're seeing a difference with that test, but not with the other one, which was possibly too easy for everybody. And the effect size of the double-digit score was about 0.23. So a further analysis where we adjusted for additional parameters where we had them, such as socioeconomic status, parental literacy, and baseline health indicators. This was available in a smaller sample of students of 600, and in that subsample, both tests were significantly different between the intervention and control schools. Next slide, please. So in conclusion, our results indicate the high levels of malaria and anemia in this particular part of the world, and provide a good reason for thinking about school-based malaria control. In terms of the insecticide-treated bed nets, the malaria education increased the use of nets and basic knowledge of disease protection. But we also found that even with high reported net use, that high malaria infection prevalence may persist. In terms of the intermittent parasite clearance, it was found that teachers were very effective at administering the IPC in schools. They were known and trusted by the community, and the IPC was shown to effectively reduce both malaria and anemia in this population. The fact that the targeting of malaria was found to improve classroom attention was particularly important, as this is only the second time that this has been demonstrated. So I mentioned earlier the policy recommendation for the seasonal malaria chemoprevention, which was made in March 2012. And as a consequence of this, we began to think, although this was targeted at children under 5 years, that potentially we could see the same kinds of effects in the younger age group. And this led to a current study which is underway, which I shall just mention very briefly before handing over to Sebyou. Next slide, please. So this is a second study also being carried out in the same area of Mali. It combines seasonal malaria chemoprevention during the months of August, September, October, and November. And then that's followed by a distribution of micronutrient powders to households for home fortification of the children's food. So this is an intervention targeted at preschool children 0 to 5 years. Next slide, please. The ECD Centre is central as a rallying point for these interventions in terms of sensitization, organising parenting sessions on hygiene, nutrition, cognitive stimulation, and the distribution of the NMPs. But nonetheless, all children resident in the community are eligible to receive the interventions. The community takes responsibility for organising the administration of the interventions, and it's managed through the existing school and ECD management structures. Next slide, please. So this is currently being evaluated with funding from the World Bank Strategic Impact Evaluation Fund in 90 communities in Sikasso, 60 communities with ECD centres, who have half of whom have been randomised to the intervention, and 30 communities with no ECD centre. So the programs which are being received in these 90 communities, all communities are benefiting from IGNs to protect against malaria as part of national campaigns. All communities are receiving deworming and vitamin A supplementation, and all communities now receive seasonal malaria keen prevention. All these are part of the national programs, but in addition, the intervention communities are receiving home fortification with micronutrient powders. And we shall be evaluating this in the next couple of months, using a similar range of outcome measures as we've looked at in the older children. So watch that space. Next slide, please. So at this point, I'd like to hand over to Sebyou to take us through what's happened since that trial in schools and the implications for program managers.
Thank you, Sian. Is Sebyou there? Can we confirm or not? I think he is not. We're having some issues with the internet connection with Mali.
Helen, Sebyou is online right now.
Oh, fantastic.
Involved in this presentation. So Sebyou, you just need to take your microphone off mute.
Hi everyone, my name is Sebyou Diarra. I'm School Health and Nutrition Coordinator in Mali. Next, So in Mali, our program, School Health and Nutrition Program, has been implemented in Sikasso region. Sikasso region is in south of Mali. And the program has covered around 478 schools. Among over them, 345 schools have received IPT treatment, that's intermittent parasite clearance. But the combined as other school health program, our program is implementing deworming, iron, and vitamin A supplementation. This combined package reached around 60,000 children in 2015. Next slide. So in terms of advocacy, based on this malaria control study that Sian has presented right now, we performed the presentation of the result, the sharing of the results of this study in 2013. And another presentation sharing at the regional level has been done in 2013. Now the program is with the support of London School team. The program is the publication of many articles are in process, and we made a film, a video about our malaria control program in school, now which will be available in next coming month. And the results has been shared in South Africa outside the malaria control in school conference, the symposium and malaria control in school conferences, and in Durban in 2013. Next slide, please. Next slide. Yes. The the impact of these results is that we are integrating the malaria control program in our national strategy. Now, as Sian mentioned, the school-based malaria control wasn't the preoccupation of our national malaria control program. But due to this study, now we are on the verge to change the national strategy of malaria control in school and to make malaria control, school-based malaria control, a part of a national malaria control strategy. And now we, outside our evidence, the evidence that we find with these two studies, we are gathering the evidence to make advocacy at the Minister of Health level so that to change the national policy. And now, right now, the plan, there is a session of adaptation of a national strategic plan on the malaria control in general and in school in particular. And we are now doing the review of national strategic plan, which is underway, but will be we will find the final deliverable at the end of this month. Next slide. In terms of programmatic implication, in 2013, our program implemented the intermittent parasite clearance at school. We covered 345 schools with around 1,600 children. And the scaling up of this strategy is in process. All schools in sponsorship intervention area must be reached at the coming years. And the government intervention on malaria control are aimed to the children of preschool. And the government intervention through seasonal malaria chemo prevention take account the children of preschools. Our program focuses the intervention in the primary schools, in primary school and secondary school. Then, for this, we train the teacher, and we supervise with the implication of health centers, and all the aspects of transport and other logistic issues are taken account with are supported by Save the Children. And as mentioned by Sian Clarke, the context of Mali is particular. The region in where we are implementing our extension program have a long period of high transmission season of malaria. That make our program different from the other programs. Next slide. In terms of supply, to implement this program, we need to supply, to procure, to make the procurement of the drugs. All the drugs are by Save the Children, and it can be provided by the National Malaria Control Program through UNICEF. And some parts of this implementation costs are taken account by, supported by the government, as the rapid diagnostic test (RDT) for fever cases are provided by the Ministry of Health, and all costs, other costs are supported by Save the Children, as training of, such as training of teachers, health agents, transport, and so on. But our advocacy aims to convince the government to support all aspects of this mass treatment. But the issue is how to make this sustainable. That it is very important to focus on the sustainability of this intervention. But without the government involvement, it will be very, very difficult to make this important activity sustainable by the community. Next slide, please. And to perform the activity, we need to train the teachers, to organize teacher training session each year and before the campaign. Teachers from each school are invited to participate to the training sessions, and it is a source of motivation of teachers every year to come and to be update of the modules. Is an important thing to do, and it is a kind of motivation for teachers. And for before the teacher training session, we update the manual of treatment, the guide of treatment, and as I mentioned, the transport, the food fees. All these aspects are supported by Save the Children. And the teacher, there is no particular skill that a teacher must have in so that to participate in the session. That the head of school and one teachers come and participate to the training. If one teacher may be miss the intervention, that doesn't affect the program. We are convinced that we program manager are the key person to coordinate all aspects of this process. Next slide. So our partner are the Ministry of Health. His role is to sensitize of the community and to train, to participate to the teacher training, to supervise the implementation, the distribution of the medication by health agents, and to health workers, and to supply some small material like thermometer, gloves, and to manage the fever case of malaria. And the second partner is the Minister of Health Education. His role is to sensitize the community through school community management committee, and to allow the headmaster, the teachers to perform the intervention in school level, and with the supervision of health center members, and to report the activity, and something which is not here is to make the reference to the student who is sick must be referred to the health center by the teachers. And the last partners is the school management committee who play a key role in the organization of the distribution by sensitizing community and to encourage student parents to well prepare the children to come the day. Next slide. And in terms of integration, we can say that the intervention of school health and nutrition are the best entry point to control malaria in school. As you are now, is classic to do the deworming, school deworming and micronutrient supplementation. It is very easy for to integrate the malaria control intervention in school based on these two interventions, deworming and micronutrient supplementation and other activities. But there is some issues to be considered. Like the first one is how to manage the Minister of Health to support the activities of the program. That's something to be considered when implementing these activities. Then the second is how the local health staff will accept the intervention and we make and support the intervention in the ground. That is very important to be taken in account. And the sensitization of the community members, especially community leaders, is another issue to be taken in account when implementing this intervention. But one of the issues is the procurement of drugs, how to find drugs at the time and to implement. That is an issue to be considered. And the teachers and health agent training and monitoring and supervision also are to be considered. Next slide. Next slide, please. Yes. Now, to implement this malaria control in school, we have there are a lot of strategy, but the important strategy are school-based early detection and treatment. This activity is very important to control malaria, and the distribution and promotion of long-lasting insecticide nets in school. But this activity, in case of Mali, the government has implemented the universal coverage in nets. That is not, this strategy is not, in our case, important strategy because it is covered by the government. And one of the strategies is intermittent preventive school-based treatment. The strategy we have doing here is intermittent parasite clearance, as mentioned by Sian Clarke. And the community sensitization and supervision are some activity which complete the strategies. Next slide, please. So finally, we have some lessons. We learned some lessons through our 2 years implementation. And the first is, as I mentioned, the addition of the Minister of Health and the Minister of Education. This because we prepared the study together with the Minister of Health representatives and the Minister of Education. since the beginning of the intervention that are involved. And the community sensitization is a lesson learned, but sometimes the teachers, maybe sometimes teachers are not in good term with their community, maybe a small and difficulty for the implementation of the program. We learned that. And we learned that teachers, well trained and motivated, are very effective to do this intervention. And one thing is which we learned is the real involvement of health agents. Health agents, if they are not involved, there can be sometimes the start point of the remorse, which will be a bad thing for the implementation of the program. Next slide. Thank you.
Thank you so much, Sebyou, for very clear and very interesting presentation, raising a lot of practical points. I wonder, given the shortage of time, whether we could open up the floor to questions now. We do have some spare slides at the end about global relevance with some good references and citations that we can perhaps share with you electronically afterwards. I think that's the only way we can do this right now. Do you agree, Sian and Alicia?
Yeah, no, I was going to suggest the same thing, but perhaps if we just go to the last slide so we have it up on screen,
yes,
so that people can get those references down, but I don't think we should discuss them.
Okay. There are some questions in the column.
That one.
I'm not sure if Sebyou can read them, but I can perhaps read the one from Mohini. There's a question here about the proportion of children who are out of school and how or if they're being reached by the IPC. Sebyou, are you able to comment on that?
Excuse me, can you repeat, please?
Yes, there's a question about the out-of-school children and if they're being reached or not.
No, we didn't reach the out of school, but as we are, it is a kind of pilot. We didn't take about out of school children.
Okay. And then there's another question from Mohini about the drugs distributed to the schools. If it's a one-time supply for 5 months, or is it done on a monthly basis? When the drugs are, yeah.
The drug is not is given once time in the year. It is not as IPC. IPC is a strategy which consists to give to children one time
right.
per year.
Okay, it's at the end of the transmission season.
Yeah.
Yeah. Okay, are there any other questions? Questions. I have a question if no one else has. Oh, who's that?
Hi.
Oh, hi, Australia. So glad you can join us.
I just have a question on I may have missed the slide because I had trouble connecting to the Skype. Is there an evaluation being done on the impact to other children outside of the children that are in the program? Outside of school children, I mean.
So let me answer that. In the context of the trial, no, we didn't. We just focused on the school-age children that were directly receiving the intervention. From from a malaria control point of view within the community, it becomes interesting to know if you clear the parasites within the school-age population, because it's a reservoir of infection for other members of the community. It would be nice to know if that had an impact on ongoing transmission, but it was outside the scope of the study that we were doing.
And Sian, did you do any kind of baseline global all population parasitemia, or and then evaluate at different points in time before and after the intervention?
No, because we were primarily focusing on on the impact on the school-age children themselves. Okay. So what we do have in terms of the risk to other members of the community is the reduction in gametocyte carriage amongst the school children. So we saw an 8-fold reduction.
Okay, thank you.
Okay, everyone, I think we're going to have to round up the discussion because we are already over time, and I know that everyone has other commitments, and we need to be quite strict with the timing, I'm afraid to say. But we will be circulating this presentation to the whole group, and we hope we can continue the discussion by email or other means. Is there any final words out there? I can see there are various messages being typed.
Yeah, I can say someone's typing a message. So.
Right. Okay.
I think, whilst we're waiting for that message, I'll just say that there is this book chapter coming out in Disease Control Priorities in Developing Countries. It's not yet been published, but it should be published later this year. And so the link is there on the slide. And that might be something that talks about different strategies of controlling malaria in school-age children that may be of interest.
Excellent. Thank you, Sian. And thank you so much, Sebyou, for brilliant presentations, and to Alicia for organizing everything.
Yeah,
to all the participants.
All right. Hello again, everyone. This is Alicia. Just letting you know that next month's webinar will be held on May 16th. We will get back to you about the topic. That's going to be Monday, May 16th. And John, we see your comment there. We are going to respond to that in the email that we send out, if that's okay. And thank you very much, everyone. Have a great day.
Great weekend.
Thank you.
Thank you.
Thank you.